Now, how will be the clinical presentation of a patient with ASD? If it is a small or moderate ASD, or if it is a persistent foramen ovale, most of the times they are asymptomatic unless a complication supervenes. Whereas if it is a large shunt with a lot of left to right shunting, cardiac failure can develop, exertional dyspnea can develop, especially in the fourth decade. This is a more important problem. Why exertional dyspnea is a very important question. Whenever we exert, what is expected, doctor? The left ventricle is expected to pump more amount of blood, but left ventricle should borrow that blood from where? From the left atrium. But is the left atrium is having any blood to borrow to the left ventricle? No, because it is donating it to the right atrium. So that is the reason exertional dyspnea is a very important feature, and sometimes the left ventricular stroke volume can become so diminished because of this shunting that it can lead to the development of cardiac failure is what you need to basically understand. So how will be the chest rocking in the case of ASD? In the clinical examination, congenital heart disease, examination of the precordium is a very, very important step. The right ventricle becomes very prominent. So we have seen one more situation where right ventricle will be very prominent in the case of pulmonary stenosis. So it can cause parasternal heave typically. The pulmonary artery pulsations will in fact be visible and also palpable, because the pulmonary artery, like the aorta, is pulmonary artery otherwise is a very benign, modest and sincere, shyful creature. Aorta is a very aggressive one. But aorta's blood is pumped into the pulmonary artery. It is asked to work like aorta. So in that process, it is so confused that you can feel the pulsations of the pulmonary artery in the second left intercostal space. In fact, palpable P2 is a classical feature. There is a moderately loud systolic ejection murmur. What is the reason for it? Same principle what happens in anemia. In anemia, what happens? There is a decreased viscosity of the blood, and that will make the circulation of the blood faster. So the amount of the blood which is passing through the left ventricle into the aortic root is increasing. It will cause a humming systolic murmur, which will get corrected after you correct the anemia. Here also, from the left atrium to the right atrium to the right ventricle to the pulmonary artery, more amount of blood is flowing. So that creates an increased pulmonary artery flow leading to a systolic murmur, which is a moderately loud systolic ejection murmur, is what need to be basically remembered. Now how about the S2? This is very important. S2 has got A2 and P2 two components. P2 is because of the closure of the right ventricular pulmonary artery, the pulmonary valve. Here the right atrium to left atrium to right atrium to right ventricle, increased flow across the pulmonary valve is there. It takes longer time for the right ventricle to complete its dinner systole. So that is the reason it washes the plates little late, and the sound of P2 is heard a little late. So A2 P2 widening happens is what need to be basically remembered. Now the question is, generally only A2 and P2 become a little more separated when we have inspiration, because inspiration causes a negative intrathoracic pressure. It will suck the venous blood into the right atrium, into the right ventricle. So generally only there is an increased blood flow, venous return into the right side of the heart. So P2 becomes little more delayed. But that excess of the venous return, which occurs further with the inspiration, will not occur in the case of the ASD, because already the left atrial blood enter into the right atrium. So right atrium is house full. It won't permit any additional inspiratory venous return increase. So that's the reason it is widely split but fixed without any further increase with the inspiration is what need to be basically remembered. Now, how is the electrocardiography and the chest radiograph? There is a hypertrophy of the right ventricle. That's the reason there is a right axis deviation, and the degree of the RV volume overload will decide how much of right axis deviation is there. And typically there will be a right bundle branch block type of pattern, and suppose if this ostium primum type of ASD is there, it has an associated endocardial cushion defect also. Endocardial cushions, AV node, they are all very closely related. So that is the reason there will be a superior axis deviation